Now look at the notes for Extract 1.
Extract 1, questions 1 to 12. You hear a doctor talking to a patient called Paulina. For questions 1 to 12, complete the following notes with a word or short phrase. You have 30 seconds to look at the notes.
Hello, good morning, doctor.
Good morning. Tell me, what's your problem?
Well, I have a history of first-degree atrioventricular block and had a pacemaker placement. I feel this problem of decreased eye vision. Last time the problem lasted for about 5 minutes. That occurred 4 weeks ago when I was driving the car.
Then how did you manage to drive?
Well, I was able to pull the car over to the side of the road without much trouble. During that time, I felt nauseated and lightheaded. When I approached the clinic at that time and received a CT scan, carotid Dopplers, echocardiogram, and neurological evaluation, all of which were unremarkable. I couldn't have an MRI due to the pacemaker placement.
Okay, did that occur again?
No, doctor.
Any lesions or change in vision, headaches, change in gait, or other neurological issues?
No, doctor.
Do you have any back pain, bowel or bladder incontinence, or frank lower extremity weakness?
No, doctor.
What's your age?
57, doctor.
Do you drink or smoke?
I don't smoke, but I drink alcohol, only on some special occasions.
Any past illness or surgeries?
I had pacemaker placement for atrioventricular block, and I had bilateral knee replacement 3 years ago and have some pain in my knees.
What medications are you taking?
I have recently started on Plavix, suggested by primary care doctor. Other than that, baby aspirin 81 milligrams per day, Proscar 5 milligrams GD, and Synthroid 0.2 milligrams daily.
Are you allergic to any medication?
No, doctor.
Well, your physical examination shows your blood pressure at 134/80, your heart rate 60, respiratory rate 16, and weight is 244 pounds. Cranial nerves 2 through 12 are intact, and you have normal bulk and tone throughout. There's no cogwheeling. There is some minimal weakness at the R4 plus or 5, and possibly trace weakness at the quadriceps -5 or 5. You have decreased sensation to vibration and proprioception and vibration. There is no dysmetria or tremor noted. His Romberg is negative. You have developed transient ischemic attack. The character of his brief episode of visual loss is concerning for compromise of the posterior circulation. Differential diagnosis include hyperprofusion, stenosis, and dissection. You have lumbar stenosis. The symptoms are very mild and consist mainly of some mild proximal upper extremity weakness and very mild gait instability. You have to get a CT angiogram to evaluate the integrity of the cerebrovascular system.
Extract 2, questions 13 to 24. You hear a gastroenterologist talking to a new patient called Luke Tomlinson. For questions 13 to 24, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Hello, come on in. It's nice to finally meet you, Luke. though not under these circumstances.
Yes, of course. Nice to meet you as well. The other night in the emergency department was quite an ordeal, but hopefully you can help me get to the bottom of this.
So let's take a minute to go through the incident in the emergency room the other night to make sure we're on the same page. So when you went to the emergency room, you had been experiencing diarrhea for about 1 month. Is that correct?
Yes, that is correct. And in the 16 days prior to that night, I had experienced an intensification of symptoms. I mean, I lost about 14 kilograms in those 16 days. My stool was watery, but I didn't see any mucus. Neither was there any blood. So at first I was not worried, just diarrhea, right? But after I noticed the weight coming off, and as I was having diarrhea about 10 times a day, I knew I needed to do something.
I'm glad you did decide to do something. Your records show that you were dehydrated on admission and your respiratory rate was increased. Speaking of your weight loss, your body mass index was 17 kilograms per metre squared, which is below the health range.
Once they got me started on intravenous fluids and that special diet, I felt much better.
Yes, they started you on a gluten and lactose-free diet and gave you an extra boost of thiamine and complex B vitamin. So trying to get to the cause of your problems, none of your labs indicated an infectious etiology, and you indicated that you have not travelled out of the country recently.
That's true. No travelling or anything like that recently.
Based on your labs and description of the symptoms, I'm going to recommend testing for celiac disease. I want to stress that celiac disease is quite rare. Approximately 1 out of every 100 people have it, though most people with the disease may be unaware that they have this disease.
I have heard of that. Doesn't it have a genetic link?
It does. If you have a relative with celiac disease, you are at a greater risk of developing the disease. It's also more common in individuals with type 1 diabetes and thyroid disorders.
And it has to do with diet, correct? I know I have heard a lot about gluten-free diets lately. Is it related to that?
Celiac disease is a chronic digestive disease involving inflammation in the small intestine. This inflammation occurs when a person with the disease eats a food containing gluten and causes difficulty absorbing nutrients. Gluten is found in foods containing wheat, barley, rye, and other grains.
So in everything, basically.
Yes, it is found in many of the packaged foods you find in supermarkets and restaurants, such as pastas, processed meats, broth, sauces, and marinades.
You said you wanted to do testing. What does that involve exactly? Is it painful?
The initial screening is not painful. I'm going to proceed with caution and start with blood tests.
In the meantime, should I try to stop eating foods with gluten, just in case I do have celiac disease?
No, absolutely not. You should carry on with your normal diet. If you restrict your diet prior to the blood test, it may cause a false negative test result. Specific antibody blood tests are used in the diagnosis of celiac disease, sometimes along with genetic tests when blood test results are unclear. Genetic tests can be used to rule out the possibility of celiac disease, since if you don't have the gene, you cannot have the disease. However, it is possible to have the genes that enable the disease without having the disease.
Wow, sounds complicated.
Yes, it's definitely not a straightforward positive or negative result. Depending on the results of the blood test, we may also decide to do an endoscopy to take biopsy samples of the wall of the small intestine. We would then look at the samples under a microscope for changes of CD. As I said before, celiac disease is quite rare. So in the end, we may find that you don't have it, and that something else is the cause of your symptoms. Unfortunately, celiac disease can mimic the symptoms of more common problems, and as a result be misdiagnosed.
Okay, it sounds like I need to prepare myself for multiple procedures and tests.
Yes, it will definitely take some patience on your part, but luckily we can get started on the blood test quite quickly. I'm going to set you up with an appointment to have your blood drawn in the next couple of days. How does that sound?
Painful, but necessary.
That is the end of Part A. Now, look at Part B. Part B. In this part of the test, you will hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare environment. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You will have time to read each question before you listen to the audio. Complete the answers as you listen to the audio. Now, look at question 25. You hear a physician explaining the microlaparoscopic pain mapping procedure to the nurse. Now, read the question.
Microlaparoscopic pain mapping. At times, finding the cause for pelvic pain becomes very difficult. This is especially true in the case of pelvic scar tissue, endometriosis, fibroids, and other problems. In a pain mapping procedure, the patient is given some strong medication to make them sleep. After injecting local anesthetic medicine into the navel, the physician will insert a small bubble of gas inside the belly and insert a laparoscope of very tiny diameter inside the belly to look around. Another small instrument is inserted lower down on the belly and used to touch organs inside after the patient awakens. While touching the internal organs, the patient will denote whether the patient is getting pain when touching specific organs. For instance, if the endometriosis is causing pain, it will be tender while touching the organ with the instrument. Moreover, when the patient experiences pain on the right side, it is difficult to make out whether the pain is in the ovary or the appendix. Therefore, pain mapping could help figure this out and help the physician pick the exact procedure.
Question 26. You hear a physician discussing the role of vitamin D in lung disease. Now read the question. Doctor, could one kind of lung disease have its roots in vitamin D levels?
Interstitial lung disease is an unusual, but at times deadly form of continuous scarring of lung tissue. A new research by a cardiologist has proved that the condition may be due to low vitamin D levels. Calcifediol is the biologically active form of vitamin D that is hydroxylated by our kidneys to form calcitrol, that circulates as a hormone in the blood, playing a major role in regulating the concentration of phosphate and calcium. Its anti-inflammatory effects modulate our immune system and also have antifibrotic effects, regulate various genes involved in fibrosis or scarring. Therefore, if you have the low level of vitamin D, that may be a contributing factor for the lung disease. However, many cases of interstitial lung disease aren't related to any particular factor. Therefore, vitamin D levels may be an unusual risk factor that would be easy to evaluate. New research will focus on correcting the vitamin D levels and in finding out if the condition of the patient resolves or stabilizes.
Question 27. You hear a doctor explaining the causes of pyloric stenosis in children. Now, read the question. Pyloric stenosis. When the muscles in pylorus thicken, that narrows the opening of the pylorus and prevents the food from reaching the intestine. This kind of narrowing of the lower portion of the stomach is known as pyloric stenosis. Typically, this problem occurs in newborn children between 2 to 8 weeks of age. As the pylorus thickens, the stomach opening is blocked. Therefore, the food cannot move into the intestine. This causes a patient with pyloric stenosis to vomit, which could result in several problems. Dehydration is the major problem caused by pyloric stenosis, since the regular vomiting devoids the fluids for the nutritional need of the infant. Secondarily, minerals such as potassium and sodium are lost through vomiting, making the baby weak. Mainly, the firstborn male babies are vulnerable to pyloric stenosis. Smoking or intake of tobacco during pregnancy doubles the chance of pyloric stenosis in infants. Bottle feeding is also another cause for developing pyloric stenosis. According to findings, infants giving antibiotics in the first 15 days of their birth have the greatest risk. Question 28. You hear a doctor explaining issues caused by increased testosterone in postmenopausal women. Now, read the question. Hello, doctor. Is it essential to measure the testosterone for postmenopausal women?
Well, according to research conducted by a cardiologist, higher levels of testosterone in postmenopausal women is the main cause for their cardiovascular disease. Testosterone is a type of hormone known as the androgen in the male. Therefore, a higher level of this hormone in women causes high blood pressure, adverse lipid profile, and other unforeseen health issues. Usually, testosterone becomes more dominant in women after the menopause. However, screening for hormone levels during such health conditions is not in practice at present. Symptoms of an excessive level of testosterone in a female include excess facial and body hair, deepening of the voice, acne, increased muscle mass.
Question 29. You hear a doctor discussing the methods to control narcotics use by the patient. Now, read the question.
Hello, doctor. Is there a comprehensive approach to keeping pain under control, avoiding narcotics?
Yes, according to a pain expert who has established a multidisciplinary pain clinic engaging physicians, acupuncturists, massage therapists, psychiatrists, and patients to kick the opioid habit. One fundamental practice followed is signing an actual contract with a patient mentioning that they will not use any kind of narcotic while they are getting prescriptions from us. Moreover, they will also not do anything outside of getting another prescription from any other provider. We will tell them that we will be randomly doing urine examination, and we tell them if they keep getting positive urine tox screens, we are not going to provide them medical services, so then they have to go and find another provider. Occasionally, we get a positive tox screen, and we confront the patients, and we warn them. If it happens next time, they cannot come to our clinic anymore. Question 30. You hear a doctor arguing about nose inflammation, whether it is good or bad. Now, read the question. Hello, doctor. What can the nose inflammation teach us about how the human body repairs itself?
We have the ability to smell things because of our olfactory system. However, according to research by an otolaryngologist, for the patients with chronic sinusitis, inflammation on overdrive compromises this system. The greatest problem in patients is just the ability to smell due to inflammation, as in the case of chronic sinusitis, for instance. It's evident that chronic inflammation is bad for the olfactory system, at least in the early stages, to begin the repairing process. It is surprising that inflammation actually plays a beneficial role in early repair of tissues that allow us to smell. Therefore, inflammation is a normal and essential process in repairing. But the question is how to regulate inflammation to preserve the good and mitigate the bad.
This is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about specific aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which best fits according to what you hear. Complete the answers as you listen to the audio. Now look at Extract 1. Extract 1. Questions 31 to 36. You hear the doctor's lecture on acute cardiorenal syndrome. You have 90 seconds to read questions 31 to 36. Cardiac and renal function are intricately interdependent, and failure of either of these organs causes injury to the other organ in a vicious cycle of worsening function. We are going to discuss about the acute exacerbation of heart failure or acute cardiorenal syndrome resulting in acute kidney injury, which is a common cause of admission to the intensive care unit. Let us examine the clinical definition, pathophysiology, hemodynamic derangements, clues that help in diagnosing and treatment. Cardiorenal syndromes are a group of interconnected disorders involving the heart and kidneys, which are classified based on whether the problem is acute or chronic, and whether the primary problem is in the heart, called cardiorenal syndrome, the kidneys, called renocardiac syndrome, or another organ, called secondary cardiorenal syndrome. Although the above definitions provide a good general description, there is a necessity of further clarification of the nature of organ dysfunction. Acute renal dysfunction can be unambiguously defined using an akin and rifle classification. Here, akin means acute kidney injury network, and rifle means risk, injury, failure, loss of kidney function, and end-stage kidney disease. On the other hand, acute cardiac dysfunction is an ambiguous term that includes pathophysiologically and clinically distinct conditions. Acute heart failure and cardiogenic shock, Cardiogenic shock is characterized by an abrupt compromise in cardiac pump functioning, resulting in global hypoperfusion that is severe enough to cause systemic organ damage. On the other hand, acute heart failure is defined as gradually or rapidly worsening symptoms and signs of congestive heart failure due to worsening pulmonary or systemic congestion. Hypervolemia is the hallmark of acute heart failure, whereas patients with cardiogenic shock may be hypovolemic or normovolemic. Although cardiac output may be mildly decreased in certain cases of acute heart failure, systemic perfusion is adequate to maintain the organ functioning. However, these two conditions cause renal injury by distinct mechanisms and have entirely different therapeutic implications. Reduced renal perfusion because of renal venous congestion is now considered as the major hemodynamic mechanism of renal injury in acute heart failure. On the other hand, in cardiogenic shock, renal perfusion is reduced due to a critical decrease of cardiac pump function. Therefore, the ideal definition of acute cardiorenal syndrome should describe a distinct pathophysiology of the syndrome and provide distinct therapeutic options that can counteract. Hence, we suggest that renal injury due to cardiogenic shock should not be included in its definition. So, discussion of acute cardiorenal syndrome is limited to renal injury caused by acute heart failure. Multiple mechanisms have been implicated in the pathophysiology of cardiorenal syndrome. Sympathetic hyperactivity is a compensatory mechanism in heart failure and may be aggravated in case cardiac output is further decreased. Its effects include constriction of afferent and efferent arterioles, causing decreased renal perfusion and increased tubular sodium and water reabsorption. Different strategies can be followed to prevent acute cardiorenal syndrome. An optimal outpatient diuretic regimen to avoid hypervolemia is very critical. Patients with advanced congestive heart failure should be monitored thoroughly in dedicated heart failure clinics until their diuretic regimen is optimized. Patients should be advised to get their weight checked periodically and seek medical opinion if they observe any increase in their weight or a decrease in their urine output.
Now, look at Extract 2, questions 37 to 42. You hear the discussion of a physician with junior doctors on different types of gangrene. You have 90 seconds to read questions 37 to 42.
Hello, doctor. Can you explain different types of gangrene?
Well, the term gangrene refers to the death of tissues due to lack of blood supply and deeper invasion of infected tissues, which are broadly classified into two categories, dry and wet gangrene. Although there are many types of gangrene, all types of gangrene manifest either as dry or wet form. In the dry gangrene, there is obstruction or slowing of blood flow into the organ or part of the body that is affected. Peripheral parts like toes, fingers, nose tip, earlobes, etc. are commonly involved. Often, dry gangrene is seen in patients of type 1 and type 2 diabetes, where long-term high blood sugar damages the small arteries and blood vessels that supply blood to the end parts of the body, such as fingers and toes, resulting in obstruction and slowing of blood flow and ultimately gangrene. In patients with dyslipidemia or high cholesterol, there is a risk of cholesterol deposition and lipids called plaques within the blood vessels. In the peripheries, such as fingers and toes, this leads to decrease in the blood vessel diameters by narrowing of the lumen, resulting in formation of gangrene. Patients with peripheral arterial disease develop fatty acid deposits or develop narrowing of peripheral blood vessels. Certain conditions include scleroderma and Raynaud's disease, where the blood supply is restricted to leg or hand muscles, resulting in gangrene. Dry gangrene is usually identified by cold, painless, and dry and shriveled up affected part. However, there will be healthy skin surrounding them. The area affected appear mummified. Wet gangrene occurs due to infection and invasion of bacteria into deeper tissues after injuries, foot ulcers, frostbites, or burns. There is excessive swelling of the affected part due to release of the toxins from the invading bacteria, resulting in blockage of the blood supply and worsening of the infection as the white blood cells cannot reach the area affected via blood vessels. Wet gangrene spreads much quicker than dry gangrene and may result in life-threatening complications like septic shock. Wet gangrene appears discolored or black and often with acute and excruciating pain. There are black blisters and foul-smelling pus beneath the thinned skin at the area. Since the infection is associated with discharge of pus, it is called wet gangrene. Gas gangrene is caused by bacteria called Clostridium that is found in spores present in the soil. Gas gangrene was a common cause of death in the wars. The gangrene is caused by the toxins released by the bacteria. Gas gangrene is further categorized into three types: traumatic gas gangrene, occurring after injury; non-traumatic gas gangrene; recurrent gas gangrene, caused by C. perfringens species of bacteria. Necrotizing fasciitis is a deep tissue infection caused by bacteria like Staphylococcus or Streptococcus. The bacteria spreads deep into the skin and into the tissues and attacks the soft tissue and the fascia, which is a sheath of tissue covering the muscle. This can occur in an extremity following a minor trauma or due to the opportunity for the bacteria to enter the body, such as surgery. The necrotizing fasciitis infection, known as flesh-eating bacteria, is most common with minor trauma. A mixed bacterial infection is often the cause after surgery. Internal gangrene is caused when blood supply to an internal organ is hampered, usually by pressure from another organ or growth. For instance, in hernia, there is an abdominal opening where the intestine may get blocked, and the blocked area turns gangrenous. Noma or cancrum oris affects the face. Fournier's gangrene is a rare but life-threatening condition affecting the penis and genitalia. This disease has been shown to have a predilection for patients with diabetes as well as long-term alcohol misuse. However, the disease can also affect patients with non-obvious immune compromise. The development and progression of the Fournier's gangrene is often fulminating and can quickly cause multiple organ failure and mortality. Due to such potential complications, it is crucial to diagnose the disease process as early as possible. Death rate is very high despite antibiotics and aggressive debridement and broadly accepted as the standard treatment. Mullany's synergistic gangrene is a rare type seen in patients after surgery. Mullany's synergistic gangrene is caused by S. aureus and Streptococcus organisms. One of the recognizable symptoms is the presence of extremely painful lesions that usually form in the second week after surgery or minor trauma. That is the end of Part C. You now have 2 minutes to check your answers.